Welcome to our video on abdominal trauma. Let's begin. In this lecture, we are going to discuss blunt and penetrating abdominal trauma. For each of these topics, we will cover the definition, pathophysiology, etiologies, clinical presentation, diagnosis, and management. Let's start with blunt abdominal trauma. First, let's define blunt trauma to the abdomen. Blunt abdominal trauma is the consequence of physical trauma such as a physical attack or high-velocity impact along with damage to the internal organs of the abdomen. Now let's understand the pathophysiology. There are several mechanisms of injury that result in blunt abdominal trauma. To start with, sudden deceleration applies a shearing force on the attached organ, leading to outcomes such as distal aortic rupture and hepatic tears. Next, direct application of blunt force results in crushing injuries, most commonly affecting the spleen, liver, and kidneys. Raised intraluminal pressure of vessels due to organ compression leads to bursting or rupture of those vessels. If hollow organs such as the stomach, intestines, or gallbladder are ruptured, their contents are spilled into the abdomen, which can lead to severe infection. On the other hand, if solid organs such as the liver, spleen, or pancreas are injured, they can bleed profusely, leading to severe hypovolemia. Let's move on to etiologies. Some of the common causes of blunt abdominal trauma are vehicle accidents resulting in deceleration injuries such as seatbelt injuries. The portion of the seatbelt that crosses the lap can create a significant force on the abdomen, leading to internal organ damage, hematomas, bruising, or internal bleeding. Other causes include falls, industrial and recreational accidents, iatrogenic trauma due to compressions during cardiac resuscitation, or the Heimlich maneuver, or a sports injury such as direct trauma during tackles or other sudden forceful contact. Next, let's discuss clinical features. Typically, patients with blunt abdominal trauma develop nausea, vomiting, abdominal pain, tenderness, diminished or absent bowel sounds, abdominal distension, and rigidity. Pneumoperitoneum on imaging can indicate possible hollow organ rupture such as the stomach or perforation of any part of the bowel. Physical exam findings during blunt abdominal trauma include abrasions, contusions, lacerations, and bone fractures. One of the characteristic signs found on physical exam of patients with abdominal trauma is the Kerr sign. Let's take a minute and understand the mechanism behind it. Patients with a ruptured spleen or diaphragmatic injury often report Kerr sign, which refers to acute pain at the tip of the shoulder, due to existence of blood in the peritoneal cavity. The blood irritates the diaphragm and leads to referred pain, since the phrenic nerve and supraclavicular nerves have the same origin, that is C3 and C4. This image depicts the colon sign, which is a red discoloration around the umbilical area, due to intraperitoneal hemorrhage and may be present in patients with abdominal trauma. The next image shows the gray Turner sign, which is flank discoloration, commonly seen in retroperitoneal hemorrhage due to blunt abdominal trauma. However, it is important to remember that the colon sign and gray Turner sign are not specific to abdominal trauma and can be present in other conditions, such as acute pancreatitis. Here one can see a chest x-ray depicting pneumoperitoneum, which is air under the diaphragm. The green arrows are pointing to the diaphragm and the red arrows are pointing to the liver border. On a normal x-ray, these should be indistinguishable. However, in this chest x-ray, there is pneumoperitoneum, or air under the diaphragm, separating the two. The blue arrows are depicting normal air in the colon. Note that pneumoperitoneum can occur when a hollow abdominal organ is perforated during abdominal trauma. Now let's cover the diagnostic approach. For diagnostic purposes, it is important to take a thorough clinical history and do a physical exam. Some of the common imaging studies done during blunt abdominal trauma evaluation are fast ultrasound, radiography, CT scan, diagnostic peritoneal lavage, and laboratory workups. To start with, fast ultrasound or focused assessment sonography in trauma is the most sensitive and quick test for the detection of hemoperitoneum. More specifically, it is used in hemodynamically unstable patients to check 4 common areas where blood can accumulate. These include perihepatic space, perisplenic space, pericardium, and pelvis around the bladder for free fluid. On the other hand, radiography or CT scan are indicated for hemodynamically stable patients, especially if they have abdominal tenderness and altered mental status. When fast ultrasound or CT scan is unavailable, doctors can use diagnostic peritoneal lavage, which is a small laparotomy with the lavage catheter being placed in the peritoneal cavity to detect hemorrhage. Finally, laboratory workup, including a complete blood count, comprehensive metabolic panel, blood type and screen, and arterial blood gas should be done. This fast image depicts free fluid collection in Morrison's pouch, between the liver and the right kidney, often due to trauma. Morrison's pouch is the most sensitive area for fluid accumulation in the abdomen. Lastly, let's talk about management. For the initial assessment of blunt abdominal trauma, it is important to find any life-threatening injuries on the primary survey and less life-threatening injuries on the secondary survey. The primary survey involves the ABCDE resuscitation system. A is for airway, B is for breathing, C is for circulation, D is for disability, and E is for exposure. If the patient is unstable, laparoscopy or laparotomy are recommended. If the patient is stable with a normal primary survey, clinical observation is recommended, while if the patient is stable and has abdominal tenderness, further diagnosis with abdominal and pelvic CT scan is suggested. The next best step after this is to move on to the secondary survey, which consists of a complete history including allergies, medications, past medical history, last meal, details of the event, and physical exam, along with diagnostic evaluation as discussed previously. Note that the most common cause of death in these patients is shock. Hence, during the primary survey, it is important to evaluate for internal and external sites of bleeding, check blood pressure and heart rate, and evaluate for cardiac tamponade. In the case of external bleeding, apply direct pressure. In the case of internal bleeding, give IV fluids or a blood transfusion and refer to surgery. Lastly, if the patient has increased risk of sepsis and peritonitis, such as in the case of hollow organ rupture, one would start antibiotic therapy and update the patient's tetanus status. Before we move on to a summary, let's pay attention to trauma management in pregnant patients, which has some unique features. As in any trauma patient, the best initial approach is the same in pregnant patients too. The patient's assessment starts with checking the airway, breathing, circulation. After it is determined the pregnant patient is stable, then fetal heart rate can be assessed. If the pregnant patient is unstable, hypotensive, tachycardic, and/or hypoxic, start by giving oxygen, placing 2 large IV lines, and performing aggressive fluid resuscitation and placing the uterus to the left side if the patient is more than 20 weeks of gestation. Displacing the uterus to the left side is done because this can decrease compression of the IVC that can occur due to the large size of the uterus during pregnancy, encouraging better venous return and improving cardiac output. In terms of laboratory workup, one should consider doing a CBC type and screen and Kleihar-Betke test if Rh negative. Lastly, one should monitor the fetal heart rate if a fetus is viable, while if the fetus is pre-viable, documentation of the presence of a heart rate with Doppler auscultation is adequate. Note that it is important to check for abruptio placentae and preterm labor, so use a tocodynamometer to monitor for contractions. All of these interventions will be performed for major trauma, such as a motor vehicle accident. However, if the pregnant patient is stable and only has minor injuries like bruises or lacerations, simple fetal assessment is enough. Now let's sum up the management of the patient with blunt abdominal trauma. As an initial evaluation, you need to do ABCDE resuscitation as a primary survey. During the primary survey, you have to determine if a patient is stable or unstable. When a patient is hemodynamically unstable due to blood loss, the next step is to do a fast ultrasound. If a fast workup is positive due to the existence of free intraperitoneal blood, laparotomy is recommended. If the fast workup is negative due to absence of free intraperitoneal blood, unstable patients should undergo further diagnostics, such as repeat fast, DPL, or CT if the mechanism of trauma is significant. On the other hand, if the patient is hemodynamically stable, do a CT scan for further workup. After the CT scan, in case of low-grade injury, conservative management is recommended along with angiographic embolization. In the case of high-grade injury, laparotomy is suggested. Let's take a look at a practice question. A 25-year-old gravid female at 30 weeks gestation presents after a motor vehicle collision. What is your best approach to this patient? It can be nerve-wracking to have a pregnant trauma patient, but the basic principles of workup here are the same because what is good for the mom is usually good for the baby. What we'll add here are some additional steps and interventions to the primary and secondary survey. As part of the circulatory evaluation, consideration must be given to the uterus compressing the vena cava, which may be worsening the cardiac output. While maintaining C-spine precautions, the uterus should be manually displaced to the left side. In making the decision of stable versus unstable, keep in mind the vital sign changes associated with pregnancy. Pregnant patients have increased intravascular volume, which allows them to lose a greater amount of blood volume before their heart rate or blood pressure will change. So the fetus may be in distress due to the decreased perfusion of the placenta, despite the mother having normal vital signs. During the abdominal exam, evaluation for placental abruption or uterine rupture are critical, and these may or may not have vaginal bleeding associated with them. Immediate consultation with obstetrics is required or transfer to a facility with those capabilities. Continuous fetal monitoring with tocodynamometer should be utilized. If the patient is stable and needs a CT scan, then it can be done for pregnant trauma patients and is not associated with fetal abnormalities. Nitrazine testing should be done to evaluate for rupture of membranes. Kleihauer-Betke test should be performed if the mother is O negative in order to determine the amount of immunoglobulin that needs to be given to the mother if there has been exposure to the fetal blood. Now that we have reviewed blunt abdominal trauma, we will move on to cover penetrating abdominal trauma. We will cover the definition, etiologies, clinical presentation, diagnosis, and management. Let's first understand the pathophysiology of penetrating abdominal trauma. Penetrating abdominal trauma results in direct damage to the abdominal wall and cavity and can be secondary to gunshot wounds and stab wounds. Some of the common organs injured during gunshot wounds are the small bowel, colon, liver, and blood vessels. Also note that the most commonly damaged organs during stab wounds are the liver, small bowel, diaphragm, and colon. Here you see the external appearance of a gunshot wound with physical trauma due to the bullet. Gunshot wounds can lead to intra-abdominal bleeding, infection, or organ damage. Next, let's discuss clinical features. Patients with penetrating abdominal trauma can present with abdominal pain and possible evisceration. You should also know that patients with massive intra-abdominal bleeds may present with abdominal distension and altered level of consciousness, along with peritoneal signs. Note that when there are peritoneal signs present, it can also mean that an organ has ruptured and spilled the contents in the cavity, resulting in inflammation. When a patient presents with hypotension, tachycardia, or changes in respiratory rate, you should suspect shock due to intra-abdominal vascular damage. Here you see the evisceration following a penetrating abdominal trauma. The most commonly involved organs are the small bowel and stomach. Now let's understand the diagnostic approach. The diagnostic approach is based on the type of penetrating abdominal trauma, such as gunshot or stab wound, and the stability of the patient. First, if the patient is stable and doesn't need emergent surgery, a thorough clinical history and physical exam should be done. Second, every patient with upcoming emergent surgery should undergo blood tests such as CBC, blood typing, and ABG to determine their hemodynamic stability. In addition, to check for genitourinary traumas and acid-base balance, BUN, creatinine, glucose, electrolytes, and urinalysis should be done. Finally, in terms of imaging and invasive procedures, X-ray, ultrasound, CT, DPL, and diagnostic laparoscopy can be done based on the patient's hemodynamic stability. Let's understand each of these imaging and invasive procedure roles in diagnosis. Chest X-ray can detect pneumoperitoneum after a penetrating abdominal trauma, while abdominal radiograph can detect foreign bodies such as bullets. Radiographs are usually used in stable patients. CT scans are more often done in stable patients for the evaluation of stab wounds to the back and flank area, since the exploration of wounds in these locations is difficult. Fast ultrasound detects free fluid in the abdominal cavity and is commonly used in hemodynamically unstable patients. DPL is done in unstable patients when the FAST is negative and detects possible intra-abdominal bleed. And lastly, diagnostic laparoscopy plays both a diagnostic and therapeutic role. Since we've mentioned peritoneal lavage as one of the diagnostic tools in patients with abdominal trauma multiple times, let's take a minute and understand the process behind this diagnostic approach. Imagine a patient lying on a bed and we are seeing the lateral view. So first, a cannula is inserted below the umbilicus for blood aspiration. If there is more than 10 millimeters of aspirated blood, then the test result is positive. However, if the result is inconsistent, then we infuse 1,000 milliliters of Ringer's lactate to the abdomen, and then drain up the cavity under the effect of gravity. If the drained fluid contains greater than 100,000 red blood cells per microliter of fluid, then it's considered positive. Now let's take a look at a practice question. In what scenarios would a diagnostic peritoneal lavage be indicated or contraindicated? Historically, diagnostic peritoneal lavage was used to a greater extent than it is today because it has a high accuracy for evaluating intraperitoneal hemorrhage and rupture of a hollow viscus. Now, it is less common due to the fast exam and availability of a CT scan. We'll discuss it in terms of penetrating and blunt abdominal trauma. For penetrating trauma, if there is hemodynamic instability, then the patient will go for a laparotomy. If the patient is hemodynamically stable and does not have a peritoneal sign, then the wound should be explored. If there is fascial penetration, then the DPL is indicated. For blunt abdominal trauma, if the patient is hemodynamically unstable and the fast exam is not available, negative or equivocal, then DPL is also indicated. Previous abdominal surgery is the only absolute contraindication due to the increased risk of damaging an organ or interference from adhesions. Relative contraindications include coagulopathies, advanced cirrhosis, and morbid obesity. Lastly, let's cover the management of penetrating abdominal trauma. As with any trauma, you start with assessment by ABCDE system. If the patient is found to be hemodynamically unstable during the primary survey, one can give IV fluids and blood transfusion as needed. If the patient is unstable, emergent laparotomy along with antimicrobials and analgesics are recommended. In injured patients after the initial evaluation, it is important to put a urinary catheter to evaluate urine output and the existence of blood in the urine. Also, one can place a nasogastric tube to assess for possible bleeding in the stomach. Let's sum up the management of the patient with penetrating abdominal trauma using an algorithm. As we already stated, we start with a primary survey that includes ABC resuscitation system, where A stands for airway, B for breathing, C for circulation. Based on the initial eval, some patients may need intubation and some may need oxygen supplementation, CPR, transfusion protocol, and IV fluids. In the case of hemodynamic instability due to possible hemorrhage, peritonitis, or bowel evisceration, the next best step is emergency laparotomy. On the opposite side, if the patient is stable with signs of peritoneal penetration, local wound exploration along with additional diagnostic tests such as EFAST or DPL should be done. If physical exam and additional tests are positive, proceed with laparotomy. On the other hand, if the diagnostic tests are negative, but the patient still has signs of continued blood loss or infection such as decreased hemoglobin, hematocrit, and increased white blood cells, consider further evaluation of peritoneal compromise with abdominal CT. Positive CT results indicate the need for the laparotomy, while in the case of negative results, consider proceeding with conservative management, observation, and potential discharge. Lastly, if in a stable patient there are no signs of blood loss or infection, consider conservative management, observation, and possible discharge. Let's try another question. A 15-year-old male presents with a gunshot wound to the abdomen after cleaning a gun with his friend. After initial resuscitative measures, the bullet was removed from the edge of the exit wound. What characteristics indicate the patient requires emergent laparotomy? While this patient no longer has the foreign body in him, if he remains unstable after initial measures, then emergent laparotomy may be indicated. Key features that indicate the need for laparotomy would include signs of evisceration, peritoneal signs, rectal bleeding, or bloody aspirate from the nasogastric tube. If all those are negative, but the patient continues to be hemodynamically unstable, then he will also qualify for exploratory laparotomy. Here is a comparison of different diagnostic tests used in the assessment of trauma patients. Take a minute to pause the video here and review the key features of the diagnostic tests we have discussed throughout this lecture. Let's take a look at multiple choice question to help put together topics we have discussed throughout this lecture. A 14-year-old male presents to the emergency department after doing belly flops onto the local lake with friends. The patient becomes unresponsive after jumping down and landing on a shallow rock directly under the abdomen. He is tachycardic and hypotensive on arrival with a GCS of 8. After initial resuscitative measures, the patient remains hypotensive and a fast exam is performed. What findings on the fast exam would indicate the need for a laparotomy? A. Anechoic stripe in Morrison's pouch. B. Anechoic collection in the pericardial sac. C. No echogenic changes. D. Ovoid anechoic lesion with few septa and no wall thickening of the liver. And E. Echogenic foci in the gallbladder. This patient has had major abdominal trauma and continues to be unstable despite resuscitative measures. This question requires not only knowing the indications for a laparotomy, but also interpreting ultrasound findings. The findings on a FAST exam would indicate the need for laparotomy in an unstable patient is any evidence of free fluid. Fluid is going to appear black or anechoic on ultrasound. Morrison's pouch refers to the space between the liver and kidney that intra-abdominal fluid wall collect. So an anechoic stripe in Morrison's pouch indicates there is free fluid in the abdomen and this patient needs to go for a laparotomy. So A is the correct answer. An anechoic collection in the pericardial sac would also be a positive FAST exam because that means there is pericardial effusion or cardiac tamponade if there is right ventricular collapse. If this was the case, then a pericardiocentesis is indicated, not a laparotomy, so B is incorrect. C is incorrect because this is describing a normal FAST exam. If this were the case and the patient is unstable, then DPL is indicated. D is incorrect because an ovoid anechoic lesion with few septa and no wall thickening is describing liver cysts, which are associated with various medical conditions but not abdominal trauma and generally do not require treatment. Echogenic foci in the gallbladder is the sonographic description of gallstones, which is not an indication for laparotomy, so E is incorrect. And that concludes the section on abdominal trauma.